2017. We have a president, we have a new administration, and the first time in over 6 years we've broken the gridlock. One party has control of both houses of Congress, as well as the White House. And so that means a policy agenda can be put forward by one particular party. So starting with that, I'll turn things over to our speakers here, and I'll start with Ramesh. Following the failure to pass the AHCA, the Paul Ryan-led healthcare legislation in the House, I was wondering, what do you think the best path forward is for the Trump-Ryan coalition to enact healthcare reform and achieve their goal of repealing or replacing Obamacare?
I think that there's actually been a significant amount of progress in the Republican Party, as well disguised though that progress is, in reaching a consensus during the somewhat herky-jerky legislative process. The moderates in the Republican Party have been willing to embrace a restructuring of Medicaid that they were leery of at the beginning. The conservatives have been willing to embrace a tax credit to enable people who don't have access to Medicare or Medicaid or employer-provided health insurance to buy insurance for themselves. That's something that they've been historically pretty leery of. But there's still some distance between them.
It's been 7 years, or just over 7 years now, since the Affordable Care Act was signed into law in March of 2010. And looking back on those 7 years, I'm curious to hear your thoughts on what you think the biggest successes and challenges have been for the Affordable Care Act up until now.
I would say over the past 7 years, some of the effective aspects of it are that the pernicious practices in the insurance market, like pre-existing condition clauses, which make it very difficult for people that have health conditions that require constant medical care and expenses that come from that, to get health insurance or to maintain it. The other aspect of the regulatory system that I think is improved is the pricing. Now, discriminatory pricing based on gender, based on health conditions, has been eliminated. Community-based pricing is in effect, and all the insurance companies that sell insurance on the market exchanges have to cover an essential benefits package. I would also say that there are some limitations and some areas of improvement. The way that the Affordable Care Act was rolled out was not optimal. It was a real debacle in terms of communication and organization, structure. It didn't make the government look very good. I agree that premiums are high, and I think that we all want to pay less for our health insurance coverage. And the Affordable Care Act doesn't have all of the provisions that are needed to reduce costs.
On the topic of access, Ramesh, I'm curious, when the CBO scored the AHCA, the Ryan-led bill, they projected that 24 million people would lose coverage over the next 10 years by 2026, compared to if we were to stay on course and stick with the ACA. One, I'm curious, do you trust those numbers? And two, what can the next iteration of Republican health care legislation, the next iteration of the bill do to improve these risks to reduce access?
Well, the Congressional Budget Office is full of very conscientious and smart people who are, I think, doing their best to model the effects of health care legislation. But I do think that the model that they work with has some structural biases. That said, the flaws in the Congressional Budget Office's approach, and I should note that the model the basic model they're working with predates Keith Hall's tenure at CBO. Those flaws should not be treated as a reason not to improve the legislation to enable more coverage. I think there are a number of things that can be done. Some of those things, putting them into legislative language, particularly at the federal level, might be tricky, but one thing you could do would be, for example, to require insurers who are benefiting from the tax credit to sell at least one policy that has its premium set at the level of the tax credit. So you don't have to dip into your pocket. You can at least get the cheapest possible coverage policy at no expense to yourself. Another would be, and this would probably be something you want to do at the state level, to have state governments enroll people who choose not to purchase insurance out of inertia or disorganization or unfamiliarity, assign them a default insurance policy that is set at that same premium level, so that they do have access to that if they need it. I know some governors, Governor Walker in Wisconsin, want to be able to do that if some Republican legislation passes. So that's one, or I should say, those are two ideas. I do think also that the Affordable Health Care Act that the Republicans had, they have flat tax credit as opposed to the sliding scale one that is in Obamacare, and I think they do this for a couple of reasonable reasons. One is because they think that the Obamacare version of this is too complicated, and second, because there is some evidence that there are work disincentives to the phasing out of that subsidy. But I think they went too far in making an actually purely flat credit, and it needs to be a little bit higher for people just above the Medicaid eligibility line to make it easier for them to get insurance. So I do think there are some things that they can do to expand insurance coverage. I guess one last point I would make is, even assuming the numbers are right on CBO's part, if you say 14 million people will lose or drop their coverage if they're not required to have that coverage. I mean, there is a normative judgment you have to make also about, well, how should we regard that number if a big chunk of it represents people who are only buying this policy because they're being forced to buy it.
Continuing on this topic of access, Jennifer, I was curious, what do you believe the adverse selection risks are to repealing the individual employer mandates? Could we see some sort of insurance, sort of death spiral? And also, do you think that the framework of heavily subsidized high-risk pools that have sort of been a staple of a number of the Ryan plans, do you think that could do anything to mitigate the adverse selection problem that might come about from repealing the individual and employer mandates?
Yeah, no, I'm glad you asked the question about adverse risk selection, because I think it's very problematic in the health insurance market. Because there's a community rating component now in the Affordable Care Act, there can't be this sort of effort in what we call in the insurance market cherry picking, whereas insurance companies try to pick the healthiest population so that they can reduce the amount that they have to pay. So what we have is risk adjustment, and risk adjustment is an effort to recognize that. And so the payments and the transfers occur, and this helps with these selection issues. The risk adjustments occur based on, and the provision is based on health status. So there's some way to sort of transfer that risk in some way that's calculated or estimated through these risk adjustment measures.
Well, there are certainly people who will argue that the Affordable Care Act has succeeded in bending the cost curve downward. I think that if you look at long-term trends on healthcare inflation, if you look at those graphs, it's pretty hard to see that in them. I mean, you can see a slowdown, depending on the way you look at it, starting in 2003 or starting in the mid-1980s. You can see a slowdown that does not seem to be confined to the United States. So I don't think the evidence is very strong that it has bent the cost curve. On the other hand, the predictions of critics of the law that it was going to spur healthcare inflation don't seem to have come to pass either. And I think that one of the things that's happened is that the footprint of the law has just ended up being smaller than anybody expected in 2009 and 2010, both because, in part because the Supreme Court changed the way the Medicaid expansion worked. There was less uptake of that than there would otherwise have been. And then because the exchanges turned out not to attract as many people as people at that time thought that they would.
Continuing on this topic of costs here, Jennifer, what do you see the path forward is for payment reform. That is the shift away from fee-for-service and toward the value-based payments or ACO model. And how could this potentially change under a Republican version of healthcare reform?
Yeah, I mean, politics aside, Republican, Democratic, whatever, Libertarian, I mean, I think that, we all agree that costs need to go down in healthcare and cost control measures are required. We have had a lot of experimentation on that over many, many years within this country. And we also have a lot of experiments, again, from other countries in terms of the way to reimburse for service, pay for services. I think that there's a lot of room for more understanding from studies, from surveys of stakeholders, whether they're at the provider level, which is the supply level, the hospitals, the clinics, and the nurses and doctors and other people, and pharmacists as well, or on the demand side, and that's us, the consumers, and what we're looking for. I think there's some common ground here. We want the best outcomes for the best, for the lowest cost. So how do we get there? And what do we do? What kind of method, what kind of incentives are we providing as part of our policies to get us to that sweet spot?
Finally, I want to ask you both about entitlement reform. The HCA and the ACA, really healthcare reform over the past so many years has been primarily focused on reforming Medicaid and expanding access to health insurance, but has by and large left Medicare and Social Security untouched by and large. I'm curious, Mash, is there political will for entitlement reform under the first term of a Trump administration with Paul Ryan-led Congress, or do you think that's something that could more likely be done in a second Trump term or a future administration?
Well, President Trump during the campaign was pretty emphatic in being against cuts to beneficiaries from Social Security and Medicare. So I guess that means who knows. From the standpoint of people who would like to see the costs of Medicare and Social Security in the future brought more into line with what we can afford, what's positive is that Trump's rhetoric on those two programs was so witless and so directed at straw men that it's very easy to design a sensible piece of conservative legislation on those things that doesn't violate his stated red lines. So, for example, if you just change the index for calculating initial retirement benefits for future retirees and Social Security so that it rises with the price level, but it doesn't rise with wages anymore, you can, or at least maybe just do that for the highest earners. You're not cutting any existing retirees' benefits. You're having a very gradual reduction in the growth rate of future benefit levels, and you can make the program solvent just by doing that.
I think we need to figure out sort of how we want to, again, organize these programs and create policies to support them so that we can have the best outcomes in terms of people's ability to do what they want to do, live the American dream, have equality of opportunity, but not break the bank, and do it in as efficient a manner as possible. Entitlements are interesting, aren't they? Because, and it's even an interesting way of phrasing it. Phrasing it a little bit more like what can policy and government as a sort of instrument of the people in terms of our social contract with each other, what can we do? What do we owe each other to make our lives as best as they can be within reasonable cost limits? So I do think a lot of the action is on the cost side. You look at some of the, as we were just saying, so the Medicaid program, we have lots of opportunities to experiment across states. The Medicare program, I relationship between the government and the American people. There's a famous quote that people use to demonstrate the disconnect some people have to the understanding of the Medicare program. When sometimes the issue is brought up about changing the Medicare program, and the famous quote is someone said, you know, whatever you do, don't let the government take over Medicare. And of course, we know Medicare is a government-run program. So yet people seem to be fairly satisfied with the Medicare program. Why? Because it's a public insurance program that, again, spreads that risk equitably and efficiently, but it's more or less a private provision, so it's a private sector. So people are interacting with their private providers, whether it be the health system in terms of the facilities, but also their doctors and nurses and people that they know and want to seek health care from. So, you know, it's an interesting, I think there's a lot to learn from that program too, and understanding, and I think it also could help with this understanding of entitlements and reform, and having the, you know, the largest stakeholder, which is the American people, understand these programs better, what we all need to do, because we're all paying for the cost of these programs, what we all need to do to make them more equitable and efficient in the long run.
Well, I want to thank Jennifer and Ramesh for taking time out of their busy schedules to share their thoughts on healthcare. I also want to thank Andy, Penn Warren Health Policy Initiative and AEI for sponsoring the event, and thanking you all for coming out. I know we have a reception afterward planned, as well as a number of events tomorrow. I think we all hope to see some of you there and kind of continue the discussion there. Thank you all for